Hello everyone, my name is Maddie Bird. I'm going to be presenting Chapter 8. It is entitled Risk Management in Practice. First, we're going to discuss suicide risk. I apologize for the grim subject, but it needs to be discussed as it is a warranted concern for every therapist. Let's talk suicide risk. First, we'll discuss statistics. According to Goulet, Abby Haynes, Carney, and Worth, a survey of psychotherapists in the Mental Health Counselors Association, 71% of responding therapists reported managing at least one client who has attempted suicide. 28% reported having at least one client die by suicide. According to the World Health Organization, someone dies by suicide every 40 seconds. Clients do not always accept a therapist's efforts to decrease their suicide risk. Marsha Linehan is a founder of dialectical behavioral therapy. She was quoted as saying, "Suicide is a solution for the client and a problem for the therapist. Suicidal ideation for the intent places therapists on high alert. The therapist is to carefully and therapeutically assess and manage the client. This often places the therapist's goals and the client's goals in disagreement with each other. Here are the most recent statistics provided by the Center for Disease Control and Prevention, and published in 2015, about suicide attempts and completions." This is a direct quote from the book. "Suicide is the 10th most prominent reason for all deaths across all age groups. Women have suicidal thoughts more often than men, but men die by suicide more frequently. Suicide is the 7th leading cause of death in men and the 14th leading cause of death for women. Men use firearms to suicide more than 50% of the time. People who have origins of 2 or more racial backgrounds are at the highest risk of suicide as adults, followed by American Indians, Alaska Natives, Native Hawaiians / other Pacific Islanders, whites, Hispanics, Asians, and blacks. Suicide is the 3rd leading cause of death for children from 10 to 14 years of age. And for those aged 15 to 34, suicide is the most common reason for death, second most common reason for death. In order for a therapist to decrease the risk of death of a client, the therapist must know the risk factors. Next is a list of risk factors provided by the text. Previous suicide attempts, presence of diagnosed mental illness, strong suicide ideation, reporting of hopelessness, distress and anxiety, evidence of impulse or other self-destructive actions, access to lethal means, methods, significant psychosocial stressors, personal losses and exposure to other suicides, childhood trauma, substance abuse, and identification within the lesbian, gay, bisexual, transgender, and queer community." Cited by the World Health Organization in 2006. Let's talk about suicide assessments. Suicide assessments require time, training, and appropriate guidance to become proficient. It is important to note that asking blatant questions to a client about their suicidal ideations do not adequately assess for potential suicide. According to Jobs, Rudd, Overholzer, and Joyner in 2008, they contend that in addition to a client's subjective responses to inquiry about suicidal ideation, it is important for clinicians to administer objective symptom measures, seek out client records for historical information, recognize the difference between chronic and acute risk for suicidal ideation, and display awareness of the different warning signs and risk factors. Clients who are considered chronic risk demonstrate a history of attempts and therefore require lower stressor levels before attempting suicide each time. Clients who are at acute risk have attempted suicide once, but ultimately must be considered at the start of a chronic path. It is important that the therapist better understands the client's thoughts surrounding the first suicide attempt, which can lead to awareness of further risk or chronic risk. Cited Jobs, 2008. It is also important for the therapist to understand the difference between assessments for warning signs and risk factors. Warning signs imply immediate risk, whereas risk factors are more associated with long-standing concerns and previously identified concepts that could increase potential for suicide attempts within the client's lifespan. Research into suicide prevention is in its infancy and there is no known treatment or cures. Suicidal ideation and intent are treated in an ongoing process throughout the client's treatment. Even in the event in which therapy is ending, the client's needs are best served if the summary for current suicide risk is documented at the time of release from care. It is important that clear documentation exists and allows for continuity of care if the client seeks treatment in the future. It is important to note that no client with a history of suicidal ideation is without risk at the time of discharge. It is naive as well as at risk of legal and ethical consequences to not be of this understanding. Next, we're going to discuss intervention and documentation. This is a direct quote from the book. As a therapist, once you have become aware and attuned to watching for potential risk factors other than a client's self-report or the desire or intent to die, it is important to have a plan to further assess, document, and understand standard procedures for intervening to diminish risk of active suicidal behaviors. It is encouraged, end quote. It is encouraged that clinicians review policy and procedures of their employment setting when available. It is also important to seek out supervision, clinical or peer, each time a therapist comes across concern or suicide risk. Documentation is also a very important step in the process of managing a case with potential for death. If documentation is absent, clinicians are in jeopardy of litigation for failing to provide the accepted appropriate standard of care. In the event of an intervention for a suicidal client, it is advised that the therapist uses several components to effectively understand and help the client. The first being that the clinical attends the therapeutic alliance so trust can be built and used for joining the client, as well as the goal of decreasing their hopelessness, increasing desire to end pain, and minimizing active suicide risk. Along with these measures, the therapist develops a plan to ensure the immediate safety of the client. Next come assessment questions regarding access to weapons. Then, the therapist can determine if immediate action is needed to ensure the client's immediate safety. If the client remains at immediate risk, this might include employing appropriate resources to assist in removing weapons from the client's possession. An assessment for a higher level of care is also evaluated. During the assessment of when determining the level of care, the immediacy of the threat of suicide is kept in mind. Generally, the care system is based on employing lesser restrictions on clients if possible. When it comes to hospitalization, it is important that the therapist assess whether the client is actively trying to kill themselves or have recently tried to kill themselves, and if they demonstrate intent currently. If these are indeed true, the client qualifies for hospitalization. It is important to know the resources available in your area that can assist in managing treatment without hospitalization, as well as hospitalization when it comes to keeping the client safe. The appropriate standard of care. The appropriate standard of care would be the absolute prevention of suicide through a therapist's care. As discussed earlier, there is no definitive end to potential for suicide risk. According to Simon, the appropriate standard of care is addressed by documenting a comprehensive and evolving risk assessment process to specifically determine the foreseeability of suicide and demonstrate the influence of treatment planning thereafter. Simon goes on to say that if a full assessment is undertaken and diligence is demonstrated in collaborating with previous and concurrent professionals in a client's life, foreseeability increases. When foreseeability increases, one has a better informed ability to judge the potential for suicide action and treatment options needed. Clinical judgment can be employed through interpretation of acute, chronic, and potential factors reported in a client's life at any given time to enhance treatment and thus outcomes. End quote. When it comes to a client experiencing suicidal ideation or intention, it is imperative that a clinical collaboration with doctors and family members occurs. Doctors and family members can provide valuable information when it comes to real-life changes to acute and chronic factors in the client's day-to-day life. Next, let's discuss safety planning. Safety planning is defined in the textbook as the process of creating a set of strategies designed to use the support and protective factors in a client's life. Going into more detail, a safety plan is designed to provide the client with options and actions, steps for care before a client becomes acutely suicidal. According to Jacobs, research reinforces the idea that the therapeutic alliance is critical in the development of a safety plan. Effective safety plans are to be pragmatic, solution-based, and easy to read and comprehend. It is wise to have the client use their own words. Additionally, it is important to list and address coping skills, places the client feels comfortable and active, people to contact for support, and provide specific information to clients about professional and community resources and how to contact providers. Confidentiality. When a client is experiencing suicidal ideations, it is sometimes appropriate to break confidentiality for the client's safety. It is the ethical responsibility of the therapist to inform the client of times when breaking confidentiality is necessary due to keeping the client safe. It is necessary to obtain written authorization to exchange or release information concerning the client when working with the client's treatment team. This plan of action also helps protect the therapist from legal repercussions. Next, let's discuss self-harm versus suicide. NSSI is an acronym for non-suicidal self-injury. NSSI methods such as cutting are commonly used. Even though self-harm is maladaptive, self-harm serves as a way to regulate negative emotions. Self-harm also helps with physical engagement when emotionally numb, to stop dissociation, or to punish oneself. It can also be a way of getting attention. Clients who self-harm often do so by cutting, burning, scratching, headbanging, picking wounds, and/or breaking bones. Brown and Kimball, 2013. Self-harm is the most common in clinical disorders such as borderline personality disorder, eating disorders, alcohol dependency, dissociative disorders, and major depressive disorders. Thank you so much again for your time and attention for this presentation.